Hi there everyone. Well, I am Dr.Nitin Kumar Arora, founder of 5 Solutions and a sports physical therapist from Jamia Millia Islamia. Today we are going to discuss a very important topic, and that is cervicogenic headache. As the title of that particular poster very rightly mentioned, that we'll be discussing the differential approaches and the manual therapy based, evidence based latest treatment aspect of the same. So from time immemorial, what has happened that people were doing the same thing. If someone is coming to your clinic and people are saying, okay, headache, it's not my domain of practice, I'm sorry, I just refer you to some other physician or some other individual who is better at catering that particular issue. But do you think is it so? Because what happens is headache is an entity which was earlier believed to be something related to our cranium and brain. So along with that, with the latest researches in this area, as Dr. Karishma Chawla very rightly mentioned, that you have a variety of headaches and many of them are because of your cervical and musculoskeletal issues. So today we'll be talking about the treatment of those particular headaches which have a musculoskeletal issue aligned with them and which have some secondary issues leading to these headaches. Because the cervicogenic headache, we further call it secondary headaches. Why? Because there was something else that was going around inside the cervical spine that led to this headache. So cervicogenic. Genesis means birth from the cervical spine. So that led to cervicogenic headache. So now headache, because what happens is, as it was mentioned in the earlier presentation as well, that what happens is we have C1, C2, C3 up to C7, the spine and the vertebrae, the C1 to C8 nerve roots coming out of those vertebrae. So what happens is the C1 to C3, C1, 2, 3, these spinal roots go up to the trigeminal cranial nucleus. So trigeminal cranial nucleus that gets innervation from these and that supplies the orbital part, the frontal part and the temporal region. So what happens is when you have or some patients have issue in this cervical area, the proprioceptive fibers from the neck along with other fibers get direct sensation from this area and can radiate pain to the structures around which are supplied by the C1 to C3 nerve roots. So if we talk about why we are learning cervicogenic headache, why there is a need to master this concept, because nowadays, because of the mobile computer screens and everything, all the day round you are sitting in front of your laptops doing nothing but either working or tackling some issue or doing your college assignments. So that way what happens is this area, so physical therapist, being a physical therapist, we are gonna get a huge sum of things out of this domain only, because it's the younger generation in India and around the globe as well that's more than the other individuals. So because of such a high percentage of younger individuals, and those are the ones who get targeted with this particular diagnosis of cervicogenic headache. So we have got a huge audience to cater. Now coming to why this thing happens, it's because you take the analogy of paper. Let's suppose a paper or a chain that is weak at one part and stronger at the complete chain is very strong, but one segment is very weak. So if you pull the chain apart, the part that is very weak will get damaged and the chain will break from that weakest part. So your strength or the individual strength or the muscle, ligament, fascia, nerves, the strength of these structures is determined by the weakest component. So it will break as soon as a force that is more than the strength of the weakest component comes into action. So with this thing in mind, likewise in our cervical spine, what happens is the weakest part, let's say the muscles or the bones, if they get the particular force, the threshold value of force, it will give way. So with that thing in mind, we need to tackle this issue with utmost care. Because as I mentioned, it's the C1, C2, C3 and these vertebrae and the nerve roots that are affected. So you should be well versed with how to diagnose, how to work out, how to manage all those components which are in this area. And for managing and for targeting these areas, you should be well versed with the anatomy and the surface palpation of these areas. So talking about the surface palpation, which all muscles do you have in this area? So in this area, if you talk about the spine, so you have C1 to C7. So 7 cervical vertebrae. If you palpate the spine, okay, for this activity, I want all of you to follow me up with the thing. So you need to use your 2 fingers, keep it at this part, your cranium's posteriormost part, that is a bulging out portion of your head, that is what we call external occipital protuberance. So this external occipital protuberance, you need to place your fingers on it, and now you need to move a bit down. So moving down the external occipital protuberance, you will get a depression. This depression was, earlier it was having something called the spinous process of C1, but now it's the rudimentary process, so it has gone a bit in, so you can't directly palpate it. But yes, with the depression thing, you place your fingers at the back of your head and feel the depression. So the depression is the rudimentary process of the C1 spinous process. Now moving a bit down, you will feel the first bulging out part, and that is what we call the C2 spinous process. Now moving laterally from the C1, that depression, and C2, that bulging, moving laterally out to the side, on both the sides behind the ears, you will find the mastoid process. And at the same time, here at this angle, this and this. So this angle is what we call the mandibular angle, right? So this mandibular angle, this mastoid process, you need to keep your thumb at the mandibular angle and your fingers at the mastoid process. Now you need to slide your hand down, and here in the mid of these 2 structures, you have the spine transfer processes of C1. So on the periphery, on the outer side, you can palpate the transfer process of C1. Now coming back to the mid of the spinous processes, now you palpated C2. Coming a bit down, you will find a thick structure, 3 bones combined, and that is what we call C3, C4, C5 spinous processes. And now why are they so close together? Because what happens is, because of this extension of the spine, the spinous processes come into close approximation. So these 3 were like this, and because of the extension, the lordosis of the spine, cervical spine, they came together, and so you are feeling something sort of 3 structures together. So those are the C3, C4, C5 spinous processes. Now coming to C6 and C7, so you need not to directly find that okay, this is C5, then C6 and then C7. So you go and palpate the most prominent vertebrae in the neck region. Now that most prominent can either be your T1 or C7. Now to rule out which one is the vertebrae you are holding in your fingers, so what you need to do is place both your index and middle finger on the vertebrae. So one on the lower one and the middle finger on the upper one. So keeping your both the fingers on both the vertebrae, extend your neck. What you'll feel is, if the upper vertebrae, you can't palpate that. So C6 vertebrae, goes inside when you extend your neck, but C7 remains at its place. So if you had kept both your fingers on both these spinous processes, what you will find is the C6 has gone in, and so that is the C6 spinous process, the vertebrae that has gone in. And the one that is still protruding after extending the cervical spine, that is the C7 spinous process. So this way you can easily palpate the cervical structures. Alongside, you have some musculature around this area. You have the superficial flexors of the cervical spine and the deep flexors of the cervical spine. Now, because why we are studying these structures, the muscular structures, because these are involved in cervicogenic headache. So what happens is the superficial muscles are there on the upper side, outer side, and the deep ones are inside. So the deep seated ones are, you have longus colli, longus capitis, rectus capitis, and rectus cervicis. So these deep cervical neck flexor muscles get weakened because of inactivity, because of lesser use, because of atrophy. So what happens now, our body is so beautifully designed, it compensates. So how it compensates? It activates the superficial neck musculature. So you have the sternocleidomastoid and the scalene. So these are the superficial neck flexors that activate instead of the deep ones to compensate for their weakness. So when these muscles activate, what happens is their activity, muscle activity heightens up, it increases. So that further decreases the activity of the deep muscles, because body presumes that now the work is being carried on by someone else and it's going on easily. So why to expend more energy activating the inner ones as well, and they go into atrophy. So this way the deep muscles start getting more and more atrophy, and the superficial start getting more and more activity, overactivity. Along with these things, in cervicogenic headache patients, what you generally find is the tenderness at C1, C2, C3 spinous processes. And now you very well know how to palpate these three spinous processes. Now coming to other issues which we generally get are the trigger points around the upper trapezius, in the scalene, in the sternocleidomastoid muscle, and along with that in the pectoralis major and minor. So these muscles start getting trigger points. Now how to tackle these issues? That's the main concern, and that's the main topic we are going to cover. So coming to how to tackle these issues, it's about, I'll not say you can target all the headaches, but at the same time I'll not rather say that you would not be able to avoid any of them. You can do a lot in this thing. So the first and foremost thing you would be doing when a patient comes to your clinic or your rehab center as a physical therapist, you would be looking at his or her posture and how to observe it. So in a person who's coming to your clinic, let's say he is having some balance issues. So in case of balance issues, what happens is the sensory motor activity, the proprioception from the foot is not coming, and the body of the individual is compensating by activating other structures, and at the same time, because the balance is lesser, so as you might have read in your earlier batches classes, that what happens is, as the body's center of gravity goes up, what happens? Balance decreases, it becomes more unstable, and the center of gravity goes down, the balance increases. So the body, what will the body will do? Now because the balance component is less, the signal is less, the body will compensate. So the person will be coming with a flexed cervical spine, like compensating like this. Okay. Second thing, if a patient is having some UMN issue and let's say some sort of Parkinson sort of issue, now because of he's trying to hold his balance and he's walking fast and then looking down to catch his balance, to catch his steps. Third person coming to you would be, let's say, of a visual issue. He's having weak eyesight, distance vision is lesser, and he is not wearing his glasses, or he might not have gone to his ophthalmologist, so he has not been prescribed glasses because he did not visit an ophthalmologist, and he is presuming that he is having a headache. So what happens that he comes to you and he is looking like this because of the posture thing. What happened that he was not able to look at a distance. So what his body tried to compensate for was he tried looking at the things like this. So he tried looking at the things like this, but the body wants it should be straight, so it became like this. So the cervical lordosis increased, okay, and along with that it became forward head posture. It's flexion and then extension. So lower cervical spine went into flexion, upper one went into extension to compensate. But in this thing, your observation came into action. Okay, this thing is happening. The lower cervical spine led to modification in the upper one, and that led to pain in the neck region. And because the C1, C2, C3 cervical spine and the nerve roots and the proprioceptive fibers got activated along with the C type of neurons, the small diameter neurons got activated. So they led to the pain around the head that is being supplied by these areas. Or a patient coming to you with a whiplash sort of injury. He was or she was sitting in his or her car and a truck or a car collided from behind. And because of the inertia thing, the body was moving forward, but the head tend to remain at the same place. So because of this thing, the head remained at the same place and the inner structures got disrupted. So because of that disruption, what happens is the upper cervical spine C1, C2 that gets damaged or deteriorated or injured. So that leads to pain in the head called cervicogenic headache. Now coming to the treatment, because we got to know that there are some muscles that are tight, there are some muscles that are weak, there are some muscles that are overactivated, and there are some areas that are painful and tender. So now you need to cover up these areas, you need to tackle these issues. So to tackle the tight muscles, what you will do? Stretching. Okay. I'll not be telling you that you do this. I'll not be giving you a proper treatment plan that this is the thing you need to do this. I'll be giving you fundamentals, the concepts you can use in any patient and you can get instant results. I'm telling you, if you go with the concepts, you're gonna get beautiful results on the very first day. So stretching, which muscle needs to be stretched? Okay, I'm waiting for your comments in the comment section. I told you many muscles, these are tight, these are weak. So tell me which all muscles are tight which you need to stretch in a patient with cervical spine issue that is leading pain into the head region. Well, okay. So you have the pectoralis major minor, sternocleidomastoid, scalene, levator scapulae, upper trapezius. So these all muscles need to be stretched out in order to tackle the cervical range of motion issues that is limiting the upper cervical spine movement, and that will be counteracted with these stretching techniques. Second thing, as you have palpated these structures, as I told you how to palpate that particular spinous process, so you will be checking the joint play around that area. So you will be keeping both your hands around the neck like this and both your thumbs around the spinous process, and with this thing you will be pressing down. So you will be checking the joint play of each and every segment, and you will be assessing whether it is hypomobile or hypermobile. So the two arrays of diversion. So these ones you need to check, and if it is hypomobile in one side, because you'll be checking the zygapophyseal joints and the spinous processes. So let's say if one side of the spine is hypomobile, that is not allowing complete neck movement, and that is impinging the nerve somewhere or the proprioceptive fibers or the muscular area in this region, that will lead to pain radiation around this area, either on the temporal region or on the frontal region, okay, or on the orbital region. So the frontal region, orbital region, or the temporal region may get pain because of the involvement of the trigemino-cervical nucleus, okay, because that supplies in these areas only. Okay, and why the upper trapezius tightness can lead to these issues? Because upper trapezius has fibers coming from the proprioceptive components to the C3 and C4. So that goes directly to these areas as well. So any part having issue will can radiate pain to other areas as well, which are innervated by the same nerve structures, nerve roots. So any structure that is injured with the C4 nerve root can lead to pain in any other structure that is innervated by the C4 nerve root. So with this thing, along with this thing, what comes into action is your trigger point release. Now, because many muscles have trigger point as well, the tight muscles, they are having the taut bands and trigger points as well. So you need to release the trigger points, and the deep friction massage will work well in this condition, and the deep circular trigger point release friction will work, and you need to give that friction thing for 30 seconds. So your thumb will serve the purpose. Or else, what happens is, if you have a bigger work setting and patients are coming in quite good frequency, your thumb will give way. Your thumb is a very unstable joint. Being a small joint, it's very unstable because the mobility is very high. It can move in all the directions, but the stability is very low. So being unstable, now if you are applying pressure the whole day like this, you are doing this thing, it is gonna give way. In some days you will find, okay, being a therapist, you are having BlackBerry thumb or text thumb. So we don't want that to happen. So for that thing, what we'll do is, we'll make a grip. And what is that? We call it V grip sort of. So what you need to do is, your index finger, flex it and take it closer to the thumb. Now your thumb will be, your thumb is here, it is stopping it here and not allowing it to straighten out. Okay, this way your thumb is holding it here. Now this knuckle you will be using on the trigger point like this and this. Now you apply force. So if you do it with me, you will be finding it very good. Like next time you will be doing it, you will be finding it very easy. So try it. Your index finger, bend it, hold your thumb here, and here you go. So you have your trigger point release equipment in your hand. Okay, so this was about trigger point release. Now coming to the most important part, which I believe is very much necessary on part of teaching the patient how to tackle this thing at home, or else you are doing it in your clinic, then also it will be very useful, and that is Snag. So Snag means sustained natural epiphyseal glide. So the epiphyseal joints on both the sides, if they are restricting the movement and that's leading to pain in this area, so we need to tackle them as well. So how to tackle them on a self basis? So let me just pick up my instrument, and yeah, so here we have a belt. Okay, and now because you know where the C1, C2, C3 are, I'll be keeping a belt or a small rope sort of structure. I'll be holding it in my hand and I'll keep it here like this. Okay, I held it like this, I pulled it forward. Now one of the arm will go down because I want to do Snag on the right side. So I want to increase the movement on the right side. So what I'll do, I need to increase the right rotation. So I'll do right rotation Snag. So for that thing, this one will go down, the right one will go down, and the left one will be straight parallel to the ground. So this one down, this one straight. Tuck in your chin So this way, tuck in your chin, and now take it to the side. 1, 2, 3, relax. Again, take it to the side. 1, 2, 3, relax. So this way, so what you need to do, this belt or any sort of equipment will help you in working up with these things. So any such structure can help you, and whichever side you need to move, the opposite side you will be holding straight parallel to the ground and take it to the side. Hold for a count of 2 to 3 and then come back. Repeat 5 to 10 times and you are gonna get instantaneous results within a short span of time as soon as you do the very first movement. So these are the things which are of utmost importance. Another thing, now you are doing treatment for your patient, well and good, you are an amazing therapist, but how to assess yourself that how your treatment is going? So for that thing we have got something called deep cervical neck flexion test. So the deep cervical muscles of the neck, the neck flexor muscles of the deep cervical neck flexors, their endurance you need to test. So how to test that and how to test if it is getting better or not. A research was conducted and it was found that the deep cervical neck endurance test came out to be more than 38 seconds in normal individuals, and in the ones who were affected by cervicogenic headache, it was less than 24. So let us go through what it is. In this test, the patient will be lying supine and then what he or she will be doing is they will be using their deep neck muscles to tuck in the chin. So tucking in the chin, and then they'll lift their head off the bed. The other hand of the patient will be at their neck to assess as if their sternocleidomastoid is not being activated. So flexing your spine can either be done with your SCM, sternocleidomastoid, or your deep muscles. So the person will be holding his hand here to palpate if this muscle is not being activated, right? Because we don't want this one to activate, the superficial muscle to activate. So that way we'll be checking the ability of the deep cervical neck flexors to endure this stress. So in the patients who were having cervicogenic headache, they were able to hold this position and take off their head off the bed just for 24 seconds. And in the other ones who were normal, it was found that it was more than 38 seconds. So there was a quite 14 seconds difference in both of them. So that's quite significant. So if your cervical flexion time, the endurance test time is increasing, that means you are going great. Your endurance, the patient's endurance is increasing. And here I would, the term patient came into action. So I would like to correct myself and to correct you people as well. Generally we use the term patient. I believe that a more patient-centric term, that is, it should not be oriented to disease. You should be saying an individual with a particular issue, not like a patient. So everyone is an individual and cater them with this issue. Okay. So with that thing in mind, and along with that, now the cervical flexion test, you are done with it. Along with this thing, now your upper cervical spine and your head, they are counted, they are rectified. There's one more thing that needs to be taken care of. It's your scapular muscles, because generally what happens is in patients with cervicogenic headache, they keep on roaming around because of our healthcare structure. People are not being diagnosed that they're actually having cervicogenic headache. They take treatment for sinusitis, for cervical headache, normal headache, their migraine, tension headache, and anything, you name it, and they get it diagnosed with, and then after 5 years, 2 years, 10 years, they get actual issue that's happening when they find a nice physical therapist like you. So then they come to know that it is actually cervicogenic headache. So then your action, and then you do the treatment, and they get relief on the very first or second day, and they praise you a lot. So this is a domain which is gonna work wonders for you. So talking about the scapular muscles, so scapular muscles, what they do is, in patients with cervicogenic headache, the posture is something like this. Okay, normally I'm standing like this, and they are standing like this. Forward head and round shoulders. So rounding of the shoulders. So what is happening is, pectoralis major, as I mentioned, was tight, so this led to this thing, and pectoralis minor was tight, so that led to anterior tipping of what? Scapula. So anterior tipping of scapula because of pectoralis minor, and anterior, forward this round shoulders because of the tight pectoralis major. So what we need to correct, and at the same time the posterior chain is very weak, so we need to activate the posterior chain and we need to stretch it out. So the pectoralis stretch along with activating the posterior weak chain of the scapular area. So cervical retractors need to be strengthened up along with stretching the pectoralis area. So as much as you can stretch it, and then this thing. So these things need to be taken care of once you can stretch it out properly, along with targeting the back muscles. Because whenever you stretch a muscle, the length can only be maintained if the opposite muscle is being strengthened as well. So then only you can maintain this length. Otherwise, it will come back to normal in a few days. The patient will get relief, and after a few days, he will be complaining, I'm coming back to the same position, I'm getting the same pain again. So for that thing, you need to activate the complete posterior chain. And how to activate the posterior chain? You need to work up on your muscles of the scapular area. And how to work up? We have a specifically designed program that we call the scapular strengthening, or the other way around, YIT exercise. So in this YIT exercise, what you need to do is taking both the arms up with the patient in prone, with the individual who's having that issue in prone position, and taking both the arms up and holding them for a count of 5. Then repeating it as much number of times as they can, like as per your recommendations. It will vary according to patients as by their endurance times. Then taking the arms to the side, 90-90 position on both the sides like this, and then taking it back. So this position again, number of repetitions and frequency varies with patient to patient. Third position is both the arms back and taking them back and up in the prone position. So these 3 activities needs to be repeated twice daily, and the number of fit principle needs to be followed according to the ability of the individual. Now along with that, you need to strengthen the deep cervical neck flexors. So for strengthening them up, you need to do certain activities. You will start with the most basic activity, and then you will move in the gravity planes. And so first is gravity eliminated or lessened plane. Then second is a gravity resisted plane. Third is the sitting position. So in the first one, what you will be doing is, you will make the individual do what? So he or she will be lying in supine position, and you will tell them to tuck in their chin. In supine lying, tell them to tuck in their chin. Because they are lying supine, the gravity will be pulling their neck down. So that is very easy for them to do. Even if they are novice, they are new to this treatment, they can easily work upon this. Just instruct them to tuck in their chin while lying supine. In this thing, you need to be very cautious that they are not activating their sternocleidomastoid. And where is the sternocleidomastoid? You turn your head to one side, this sharp crease, and this one is your sternocleidomastoid. So this one should not be activated because it is superficial flexor of the spine, and it is generally overactivated in patients with cervicogenic headache. So this is what you need to take care of, and then you progress to the next position once the patient is getting better, he is improving. So then in the prone position, what you need to do is make them lie in the prone position with a towel roll under their forehead, and then instruct them to tuck in their chin. This one again, progress as they get better. Third one will be in sitting position. They will be sitting comfortably with their head at the wall, and tell them to tuck in their chin. They'll be, sitting with the wall and they'll be tucking in their chin and holding it for a count of, let's say, 5 or 10. If the individual is an old age person with multiple comorbidities, I suggest you not to increase the hold time more than 6 seconds, because more than 6 seconds hold time leads to something called Valsalva maneuver and can increase the peripheral vascular resistance. That will lead to increase in the resistance of the periphery vessels and leading to increased effort of the heart to conduct blood to these areas. So this is what we don't want to happen. So these things needs to be taken care of, and your assessment will be guiding your treatment. So you will be asking your patient everything ranging from, as Karishma Chawla very rightly mentioned, that you need to ask them how many number of times they get their pain, that headache, what is the duration of headache whenever they get it, what is the type of headache, is it burning sort of, it is pressing sort of, and how many headaches do they get in a day or a week or a month. And then as your treatment progresses, you can again follow up and assess whether the number or frequency of headache and the duration of headache is decreasing with your treatment or not. If it is decreasing, then you are on the right track. So congratulations. So with these words, I would like to say that it is your utmost importance to take care of these things. And last but not the least, what you need to take care of, that it is you who can avoid the actual progression of the disease. And even if the individual is not deceased, you can avoid the happening or occurrence of the issue. So how can you avoid this thing? So because we can target the musculoskeletal and nervous components of the individual, you can tell your patients, you can tell the people who are coming to you that they need to take care of their posture, and what all postural considerations do need to take care of. First and foremost, they should not be walking like this. And how can they avoid this? By cervical and deep cervical neck flexor muscular strengthening. Second thing, what they can do is, while working on their laptop's upper screen, the laptop's upper border should be at their eye level. So they need not to bend their neck down or take it up to look at the screen. Third thing, what they'll be doing is, whenever using their phone, you should not be, typing with your thumb. Rather, use the fingers to type. Hold the phone in the other hand and then use the fingers to type. Because you have got 4 fingers, you can easily type and you will not be putting strain on your shoulder and then your neck muscles. And on part of that thing, if you are holding phone in your one hand, okay, so I am holding my phone, let's say in one hand. So what I'll be doing is, I'll be using it like this. My arm's weight will be lying somewhere around here. The center of gravity of my arm will be somewhere around this part. Gravity will be pulling it down like this, but thanks to my shoulder muscles, they are helping me holding it here, along with my scapular muscles, which are working against gravity to hold my arm against this gravity thing. So what happens is, but because of this overuse, because all the day around I'm using my phone like this, so what happens, these muscles get fatigued and overused and they go into atrophy. That's what we call overuse fatigue or overuse weakness. So that is why we should hold the phone in both the hands and type with the fingers. So these things needs to be taken care of whenever you are dealing with a patient with cervicogenic headache, because your treatment will be lasting around, let's say, half an hour, 45 minutes, but the other 23 hours and 15 minutes are with the patient, and you never know what they are doing at their homes. So you should be well considerate that patient education on your part should be ultimate, that you guided them the best way around, and then whatever they are doing, it's their responsibility that they should follow what you told them. So with these words, I would like to conclude. Thank you so much. Take care. Stay connected.